Dr. Viswa Jyothi and to participants. So Dr. Viswa Jyothi Madam is our intensivist and who is always encouraging us to carry out these knowledgeable sessions. Thank you, Madam. So today's session is about restraints in a hospitalized patient, a nursing perspective. So here we are going to discuss something about restraints and the nursing care of a patient who is on restraints, different types of restraints and its applications. So restraint remains one of the most controversial and dangerous measures used today in settings that provide services for people with disabilities or people whoever is in need of restraints. Restraint is an intrusive and dangerous intervention that can have significant adverse implications for physical and emotional health of an individual. And moreover, restraints, rather than a procedure, it is a policy or protocol that should be implemented after trying of all nursing alternatives only. If all the nursing alternatives are failed, then only we are supposed to go for restraints. So it is called as a policy or protocol rather than a general procedure. If you take bed bath or back care, need not to get consent from anyone, need not to get written order from anyone. Based on the client situation, we can go ahead for bed bath or head bath, whatever it may be, the other nursing procedures. But whereas coming to restraints, there must be a protocol, there must be a written doctor's order, and with the consent of the family members or guardians of the patient only, we should go for restraint. That's what it has played a greater role in nursing care. So the word restraint has derived from the Latin word, which means abstinentia. Abstinentia stands for absence of movement. So an important component of quality is safety. And as we know, the one of the safest measure to provide for patient is by applying restraints. Of course, it is next to nursing alternatives. We shall discuss what are the nursing alternatives as a part of this presentation. Restraint is defined as the intentional restriction of a person's voluntary movement or behavior, or it is also said as a device which limits or prevents freedom of movement. And we have many types of restraints. We shall discuss as the slides goes on, and we'll see about the purposes of restraints. As all of us knows, the first and foremost purpose of restraint is to save the clients. We might have seen a number of patients, or we might have been experienced that many patients in emergency ward or in ED room will come with a lot of irritation, especially patients from neurology or neuropsychiatry. So some clients may harm themselves, and whereas some clients, they may harm others. To avoid all those things and to provide safety for the patient, we are going to use restraints as per protocol. So that is the first purpose of restraints. Also to limit the client's movements during any procedure or during any treatment which is prescribed for the patient, and to provide constant immobilization for carrying out different procedures, to maintain client in a prescribed position based on the need, and to complete diagnostic and therapeutic procedures, we used to go for restraints. Apart from that, sometimes just to carry out physical examination, also we need to restrain the patient based on the agitation or based on the status of the patient. And it also very much useful to avoid pulling of the tubes. Mainly one patient is assigned for one treatment, and that patient is very irritable. He is pulling out all his Foley's catheter, nasogastric tube, central line, IV cannula, etc. And this restraint is gonna to be the best suitable method to continue the treatment to the patient. And also indications. We know there are so many indications. The first and foremost indication is to save the life of the patient. When the patient's life is in dangerous situation, when the patient is not cooperating, then we must restrain the patient and start giving treatment with the consent from family members. Also, when the patient is pulling out his IV lines, catheters, as we discussed already, that is one indication. And when the patient is displaying behavior that is putting themselves at risk of harm, even the risk to others. And the patients who requires urgent life-saving treatment, and the patient is demented or delirious and does not understand the treatment plan. These are the indications or some indications where we can apply restraints to the patient. Also, when the patient is physically combative, very irritable, And when we try for all alternative nursing measures, when all the alternative nursing measures have failed, then the last option is going for restraints. And we all know some of the contraindications to restraints. Of course, however emergency it is, but still there are some contraindications, like restraints cannot be applied to patients whoever is with a cardiac compromise or drug intoxication and breathing related medical disorders, because all these issues will increase the risk of death due to spontaneous apnea. Also, restraints cannot be applied to morbid obesity because of the increased risk of death due to asphyxia. And restraining of an elderly person is high risk procedure, because their mental status, their orientation, everything has to be taken into consideration. And the restraint should be applied with the minimum number of staff or with some mechanical device. Large numbers of staff members are involved in taking down care of the patient, or large numbers of staff are trying to stop the movements of the patient. It is strictly avoided. I have mentioned some case scenarios also regarding this issue. And when we see the general principles of applying restraints, restraints should be used to restrict movements only as much as necessary. Need not to control the whole body movements of the patient. Whatever part we have to be restrained, only that has to be restrained, either if it is leg or arm or abdomen, whatever it may be. And need not to restrain the total body. And restraints should not interfere with the treatment plan prescribed by doctor. And before applying restraints, bony prominences should be padded before applying it, and should be used for shortest amount of time. And that too, we have to monitor for every 15 to 20 minutes. And when you want to remove the restraints, remove one restraint at a time and watch for the client's reaction before removing the next. Like in case of 4-point restraint, 5-point restraint, 6-point restraint, at a time we cannot relieve all the points. First, we should relieve one area of the patient, see the patient's response, then go for removing of the second point of restraints. Based on that, we should wean off the restraint to the patient. And never apply restraints over an IV site. Ensure that IV and other tubings and equipments are not interfered by our restraints. And do not give too much tight knot, should be able to quickly release the device. And whenever we apply restraints, we should apply a knot which should be easily removable. And what do we call that knot is, it is known as handcuff knot. So this is the procedure how to make a handcuff knot. First, we should make it into 2 loops and overlapping of the one loop with each other, and pulling the loops out with a sufficient size as to insert the hand or leg of the patient. Then tighten to complete the knot. When we apply handcuff knot to the patient, when we apply restraints, it is easy to remove also. And when we want to remove for emergency reasons, we can just pull out the loops and easily it comes out. So this is the one of the best advised knot when we apply restraints. And this is also another point, that when we apply restraints, we should not tie to the side rails. Rather, we should tie it to the bed of the patient and should secure away from a client's reach. The client should not reach the knots. Otherwise, the client may pull the tubes, the restraint will be removed easily, and should be attached to bed frame, as I told you, not to the side rails. Observe the restraint for every 15 to 20 minutes to prevent the development of complications, and should be removed once in every 2 hours. Remove once in every 2 hours, observe the condition. Based on the condition of the patient, reassess the patient. If it is needed to go for restraint, again you can apply the restraint. But as per the protocol, every 2 hours we should relieve the restraints, whatever is applied to the patient. And do the recording and reporting properly with noted observations, like any redness of the area, or what was the status of the patient. Everything we have to be documented. Always select the safe and appropriate restraint. We should know first for which area we have to be restrained, whether it is hand or the leg or the abdomen, etc. So based on that, we should select appropriate restraint, which will serve the purpose, whatever we are trying to do. In case of children's, first you demonstrate the restraints on a doll so that to win the cooperation and confidence of the child, we should first demonstrate on a doll, then later we should apply to the child. In case of children, this is one of the best suitable method to gain the cooperation of the children. And the restraints should be changed when they become soiled or damp. And coming to reasons for restraints, so there are a lot of studies they have conducted to rule out the reason or the most causes of applying restraints. So 82% of restraints are applied to protect the patients from falls and accidents. 59 to 72% of restraints are applied in order to give treatment to the patient or in order to maintain therapeutic devices in place, like IV lines, central lines, Foley's catheters, whatever it may be. And 67% of the restraints are applied to protect others from combativeness. This is done in case of agitated patients, neurology, neuropsychiatry patients. And 65% of restraints are applied for patients whoever is with confusion, because the confusion may create them a kind of delirium and in which they may harm themselves or they may harm others. 22% of the restraints are applied to prevent wandering, is nothing but skipping away from the ward, to keep the patient in his position or to keep the patient in the ward until the treatment is over. We'll apply restraints, which comes under preventing wandering. And 13% of the restraints are applied to prevent from bothering other patients. And 12% of the restraints are applied to encourage rest to the patient. And coming to guidelines of restraints. So the first and foremost guideline to apply restraint is there must be a written doctor's orders. Never it should be taken as granted for PRN, Prorinita. It is not like copying the drugs from before page to next page. It is not like that. Every time whenever we want to apply the restraints, there should be a written order from the doctor. The doctor has to identify the condition of the patient. The doctor has to advise us the type of restraint to be applied. Of course, we can give suggestion based on the condition of the patient, but the initiation has to come from the doctor. Then informed consent. We nurses, we are responsible people to collect consent from the family members or guardians of the patient. Sometimes the patient is quite conscious, but still in order to restrict his leg, which has underwent some surgery, in such cases, we can explain the procedure to the patient himself. And always remember the restraints has to be least restrictive, which should not restrict the movements of the patient. And that is very important, repeated point, that we should pad bony prominences when we are applying restraints to prevent the development of pressure sores. And as I have told you already, never be written as a standing order or PRN. Every day it has to be updated. Whenever you want to apply restraint for the second time or third time, there must be a physician's order. Also follow proper technique when we apply restraints. Maintain good body alignment of the patient. Otherwise, there is a chance to develop contractures and some muscle spasms to the patient. And be time specific and be discontinued at the earliest point of the time. When we know when we have to remove the restraints, when you go on assess the patient, assessment plays a very important role in removal of the restraints, which we will discuss. And these are the different types of restraints. As I have referred many material, there are different types of restraints are available. Some sources tells physical separately, mechanical separately. Some sources tells both are equal. And some sources also gave me an idea about the least restraining devices. And some calls them as preventive devices. So there are many sources which gives us much information about types of restraining devices. Here I have mentioned some types which are commonly used. Number one is mechanical or physical devices. These are also known as postural supports or protective devices. The example for these devices are mummy restraints, wrist restraints, ankle restraints, abdominal, elbow and knee restraints, jacket and straight jacket restraints, crib net restraints, safety belts, side rails, splints, mittens, and belts. These are all the examples which comes under mechanical or physical. So what is physical is when we apply something manually is called as physical. When we apply something with the help of a machine or with the help of some equipment, which is known as mechanical. Except this difference, both mechanical and physical restraints are similar in its purposes. And coming to the second one, chemical. So some of the medications used to calm an individual's behavior, for example, tranquilizers and hypnotics. And the third one is technological surveillance. This is nowadays, the technological surveillance takes an important role in monitoring of the patient. I cannot tell you the word technological restraints, but which is rather known as technological surveillance. We'll see what is that. Psychological restraints and environmental restraints. And you know, these are some examples of the restraints. The first one is known as wheelchair belts to make the patient in position to prevent falling forward and to prevent falling of the patient. We will be using the wheelchair restraints. And the second one, you can see 2-point restraints. This image tells about 2-point restraints where we have applied restraint to arm and to the leg of the patient. This is known as 2-point restraints. And this is known as abdominal restraints. And these are the side rails. Most of us will be using side rails in a bedside settings. And this is also a kind of abdominal restraints, elbow restraint and straight jacket restraints. And these are the safety belts, which comes under mechanical restraints. So these are the different restraints. When we want to immobilize a particular part of the individual, we'll be selecting based on that. And I'm always telling you there should be a doctor's order which type of restraint has to be used. And as I told you, there are some types of restraints which are called as the least restrictive restraints. So the least restrictive restraint to correct the problem like falls and dislodgement of the tubes, lines and catheters is used when restraints are necessary. So these restraints from the least restrictive to the most restrictive. So the examples of least restrictive restraints are mitten restraints, wrist restraints, vest restraints, arm and leg restraints, and some of the leather restraints, which are also used to prevent violent behavior. So here, the first one is called as mitten restraint. The second one is the vest restraints, and this is the arm restraint, and this is the leg restraint. It is just restraining the particular part of the patient. So these are known as least restrictive devices, and of course, which comes under physical restraints. And this is about the protocol or policy to apply restraints. Every hospital will have their own policy. So this is the policy in general. When we want to apply the restraints, we should follow some policy. So this is in general, when we want to apply physical restraints, when you think that patient needs restraint, first as a nurses, we should apply alternative measures. When we apply alternative measures, if those are effective, yes, no need to go for restraint. We can continue our alternative measures algorithm for the management of agitation. But again, once in every 2 hours, we have to assess the patient. Again, if the patient needs restraint, again go for implementing of alternative measures. If those are effective, then no need to apply restraint. The opposite arm of this is not effective. When our alternative measures are not effective, in spite of implementing all the nursing alternative measures, still the patient is so agitated, then we have to restrain the patient. For that, we have to prepare the environment and the patient, and we have to introduce some of the measures which are applicable for application of the restraints, maintenance of the restraints, assessment of the restraint. And when we assess the restraint, when we assess the patient, if you feel after 4 hours, after 1 day, after 2 days, if you still feel the patient needs restraint, we can continue the restraint. Or if you feel that patient is cooperating, patient irritation has been reduced, then we can remove the restraints. So this is some example which tells about the protocol of restraints. Every institute will have their own protocol of applying restraints. So some of the side effects, for everything there will be a side effect. So we shall discuss some side effects of the physical restraints. The side effects can be said in terms of physical and psychological. Coming to physical, as we know, pressure ulcers, skin trauma, poor circulation, and compression asphyxiation. There is a study which tells that out of 7,500 patients, when they do postmortem, 27 patients have died with the compression asphyxiation, which has resulted with application of the restraints. So, compression asphyxia is a death that occurs when external pressure on the body interferes with the breathing. And the other physical side effects of restraints are dislocations, fractures, increased constipation because of decreased bowel movements, and increased risk of fecal impaction, infections, contractures. When we are not keeping the patient body in proper alignment, as I have mentioned, it could cause contractures. It can cause contractures. And the psychological side effects are dislike for the hospital, dislike the nurse, dislike the health team members, and the patients will develop a kind of depression, incontinence of urine and fecal matter, difficulty in developing body image, and the patient's violent behavior sometimes may increase also. These are the some side effects of physical restraints. And this is the important part of our discussion. What are the main nursing responsibilities when you apply physical restraints to the patient? I cannot tell you this point is main, this point is less. No, every responsibility plays an important role. So first, we should assess the client's behavior and the need for assessment. Though the doctor has given us order to apply restraint, it's our responsibility to assess the patient's behavior, whether he really needs the restraint. Sometimes in their busy schedule, doctors might have not observed the patient correctly, or doctors might have not interacted with the patient. Being a nurse, we have to interact the patient and assess the behavior of the patient. If you really feel that patient needs restraints, then go ahead with the doctor's prescription. If you need some changes in that restraints, we can always discuss with the doctor, then do implement the plan and explain the procedure and reason for the restraint to the family members, because we are going to take consent from the family members, and it is going to be written consent, not the verbal consent. And the minimal components of orders for restraints includes the reason and the rationale. Being nurses, we should not blindly do whatever is written on the case sheet. You should know the reason for what we are applying restraints and what type of restraints we have to be applied, and must communicate with the client and family members, because we have to get written consent. Arrange adequate assistance from competent staff before carrying out the restraint procedure. So when we apply restraints to the patient, not least restrictive restraints, when we apply the restraints which restricts the body movements of the patient, like abdominal restraints and all, we need to take care of patient's biological and psychological needs. And it is our responsibility to review the restraint regularly or according to institutional policies. Monitoring the client during restraint is very important. We have to monitor the physical status of the patient, emotional status of the patient. Also, we should monitor, is the patient safe, or the restraints are still in place, or the restraints are safe, and is the patient comfortable, is the person confused, and is the patient angry or agitated still. So these are all the things we have to monitor in the client. And after the restraint is applied, we have to monitor at least every 15 minutes for first hour by a qualified nurse. And later on also, for every 15 to 20 minutes, we should monitor the patient. And once in every 2 hours, we should release the restraints. And based on the need, again, we can go for reapplication of the restraint. And apart from that, the nursing responsibility, the important nursing responsibility is with the documentation. It is our responsibility to document whatever we have observed with the patient. because when something happens to the patient, our documentation is going to protect us from the legal issues. And also it is our responsibility to provide range of motion exercises to the physically restrained patient. As we know, we are restraining the body parts and the patient is not having any movement, and that is going to raise for some other complications like deep vein thrombosis, etc. So we should always provide exercises or physiotherapy to the patient. And we also should do turning and repositioning of the individual. Skincare plays a very important role, especially when we apply restraints. We should monitor the site for any redness, edema, bleeding, and we should provide skincare as required. So when you feel that the patient's skin has been damaged because of the restraints, we should change our protocol. And checking the circulatory status of the patient on affected body part or the hand or leg wherever we have applied restraints, and providing for all other physical needs for the patient like toileting, hydration, nutrition, etc. These are all the nursing responsibilities of a patient, whoever is on with the physical restraints. And the second type of restraints are known as chemical restraints. So chemical restraints include any drugs that is used for discipline or convenience and not required to treat any medical symptoms. These are some of the psychoactive medications used not to treat illness, but also to intentionally inhibit the movements or behaviors of the patient. Chemical restraints are any form of psychoactive medications, not to treat illness, but to inhibit the movements of the patients. And we should know why and when is chemical restraint required. A chemical restraint is most often administered in the emergency department when prompt action is required to avert violence or manage dangerous and uncontrolled behavior in an agitated patient. A patient may be agitated due to a number of reasons, due to various factors like substance intoxication, withdrawal syndromes, significant physical illness, mental health crisis, confusion, and anxiety. So see which patients needs chemical restraints, and we should proceed as per the protocol. And considerations before the administration of chemical restraints: see whether the patient is able to make rational decisions. If so, you can grant it that patient is cooperative and patient is confident about his status and patient is cooperative. So those who can able to make rational decisions need not to go for chemical restraint. So check whether patient can able to make rational decisions, and if the patient poses a serious threat to themselves or to others, if the restraint is not administered, and if the patient has any health condition that precludes use of chemical restraint, because we are going to see the different side effects of chemical restraints. If we see that particular patient is not in the criteria to receive chemical restraints, then we have to wait for discussion. If there are medical causes for agitation such as low oxygen, dementia, low blood sugar, and delirium, in these conditions also immediately we need not to go for chemical restraints. And legal considerations also should be considered before applying chemical restraints. And the need for extreme caution when we are using chemical restraints, because we are using different drugs on the patients. We should be very careful with the dosage, especially when we are giving in pregnant patients. Use appropriate medications and dosages. And these are some of the drugs which are given as part of chemical restraints. The first one are benzodiazepines. As all of us know, benzodiazepines are sedative drugs effective in aggression reduction and quick sedation in an agitated patient. This drug class is useful for patients with alcohol intoxication, withdrawal symptoms, seizures, disorders, etc. So mostly the benzodiazepines are the examples of benzodiazepines are lorazepam and midazolam. So these are the two examples, that is ativan and midazolam are the two examples of benzodiazepines. The second classification of drugs are antipsychotics. These are again typical or classic antipsychotics and atypical antipsychotics. The drugs comes under typical psychotics are haloperidol and droperidol. And the second generation drugs are atypical antipsychotics. The drugs which comes under this are risperidone, ziprasidone. And many studies have demonstrated that droperidol resulted in a faster control of the patient, shorter duration of the effect, and more consistent sedation and smaller incidence of EPS compared to haloperidol. And these are the different drugs which are used in chemical restraints with their dosages, routes, onset of action, and half-life and disadvantages. Main disadvantages of haloperidol are EPS, extrapyramidal symptoms. And droperidol, when we use it up to 2.5 mg, it is okay. But when we are using repeatedly 5 mg dosage, there should be a consideration of protocol from FDA. And coming to risperidone, it is orally dissolving tablet. It is available in the form of orally dissolving tablet, and the onset is within 30 to 60 minutes. Half-life is up to 20 hours. And olanzapine, the main side effects of olanzapine is CNS depression. And the ziprasidone, the main side effect is QT prolongation. So being nurses, we should know what drug they are giving. Based on that, we should plan our care. Like in case of ziprasidone, we should monitor the ECG and we should take ECG frequently for the patient, because we know one of the side effects is QT prolongation. So we should have an idea about the drugs used in chemical restraints. So based on that, we can plan our care according to the drugs. And every method or every procedure have some side effects. In a similar way, chemical restraints are also having some side effects like respiratory. For benzodiazepines, respiratory depression. So it is nothing but shallow and ineffective breathing, hypotension are the commonest side effects when we give benzodiazepines for the patient. Also, extreme somnolence, as we all might have seen in ICU patients, extreme sleepiness is one complication of chemical restraints because it is associated with some sedative drugs. And the examples of atypical antipsychotics are extrapyramidal symptoms, high fever, muscle stiffness, weakness, increased heart rate, etc. And agitation, withdrawal, functional decline, movement disorders, orthostatic hypotension, memory impairment. These are the some chemical sedative side effects. And the nursing responsibilities when we apply chemical restraints are the vital signs of the patient must be carefully monitored for any side effects of the chemical restraints. As I told you, in some chemical restraints, CNS depression is the side effect. In some drugs, QT prolongation is the side effect. So based on the drug, we should plan to monitor the patient. If clinician prefers to use droperidol or haloperidol, a pre-treatment ECG should be obtained. Also, we should monitor the ECG. Continued cardiac monitoring after administration is recommended. And to minimize the legal risk associated with the chemical restraints, as we know, for any drug, we should follow some of the rights. Right patient, right medication, right route, right dose, right assessment, right documentation is very important to provide safety to the patient, as well as which also save us from legal issues, whatever is happening in the next stage. And also see that everything, whatever you are doing is conforms to the established protocol of your hospital or your institute. And see that there is a physician order for giving chemical restraints. So that's about chemical restraints. And as I told you, the other type is technological restraints. Rather, it is known as technological surveillance. So what is a technological surveillance? Research on fall interventions has shown that a multifocal approach is most effective to prevent falls, especially in ICUs and in acute care settings. Currently, for those patients who are at highest risk of falls, the primary intervention implemented by all of our hospitals are use of a 1:1 ratio. That means one nurse for one patient. But this is highly costly. And after this pandemic attack, so we are having shortage of nurses. So there is one alternative. This technological surveillance intervention is quite providing of 1:1 ratio is quite costly for the healthcare organizations and has not shown a reduction in fall rates. So technology has presented the opportunity to intervene in these situations in a different manner. This healthcare organization researched the possibility of remote video monitoring as an available option to protect patients from experiencing a fall while in the acute care settings or in the ICUs. There has been reported success with the remote video monitoring for the reduction in falls. Video monitoring is described as an emerging technology that provides inpatient nurses as an additional safety tool. This observation station will allow one video monitor technician to observe and interact with up to 12 patients at a time, with the inclusion of patient care team, thereby decreasing the expense of sisters by keeping 1:1 ratio. And what are the nursing responsibilities in maintaining technological restraints? So nurses should have an updated knowledge how to use the technology, how to monitor through CCTV surveillance, and monitoring the screen when doing documentation work. It is possible. Always somebody has to be there in the monitor room, and attending alarms, phone calls from CCTV room numbers is very important. Sometimes if we miss also, one person will be there monitoring in the CCTV room where they will give us alert that so-and-so bed, so-and-so patient is moving or going to fall. So we should know the numbers of that particular control room, and we should attend the call immediately so that we can prevent fallings of the patient in ICUs or acute care settings. And do not only depend on technological monitoring when physical monitoring is possible. And there is a study which tells about surveillance technology. It is an alternative to physical restraints, a qualitative study among professionals working in nursing homes. This study tells about, especially they have implemented these technological surveillance in dementia care units. And the results of the study have shown that improvement of devices and education of care professionals might increase the support for using surveillance technology as an alternative to the physical restraints. So there are many studies which has proven that technological surveillance is one alternative for physical restraints, and it is mostly used in psychiatry settings. And about the psychological restraints, the psychological restraints are a type of restraints where we are telling the patient, it's like counseling, continuously you are insisting patient to do something is called as psychological restraints. So this is the least restrictive type of restraint and would be used in combination with any other type of restraints. But the important consideration here is using a soft and soothing voice while gently stroking the patient will help the patient to calm and soothe. The voice tone is an important tool, and emotional state can be reflected in the voice. So for example, by saying that you are not allowed to do this, you're allowed to do this, you should do like this, you should go to bed by 10 p.m. or you should awake by 6 p.m. or you should take this in the breakfast as compulsory. So like this, continuously you're telling something to the patient where patient is listening to your words and patient is following your instructions or your order and whatever is you are going to tell the patient. When you use proper skills, then only it is going to serve the purpose. Psychological restraint requires a lot of knowledge of the group's behavior. Also, it requires a lot of skills in the nurse that she should speak to the patient in a gently and quiet manner. And proper handling of the patients are very important in order to reduce stress to the patients. And there are other types of restraints are known as environmental restraints. So these environmental restraints are nothing but these that change or modifies a patient surroundings to restrict or control a client's mobility. Is nothing but we are putting patient in one separate area where they cannot get out. This is mostly implemented in children's and in people with the mild psychiatric disorders. The examples of environmental restraints are a secure unit or garden, seclusion, half doors, using of barricades, using of secure units, or keeping one security agents at the entrance gate. All these are the examples of environmental restraints. Even fencing the areas, locked gates, key gates, pads, these are all the examples of environmental restraints. When we do not want to restrain the patient physically, but at the same time, we do not want to keep the patient out of the border or out of the hospital. In such patients, we are going to use environmental restraints. So that's about different types of restraints. So the physical, psychological restraints and environmental restraints are used only in some specific situations. Like as I told you, when we want to restrict the children, especially if they're having violent or agitated behavior, and also in some psychiatric conditions. But apart from that, we do regularly use physical restraints, chemical restraints, and technological surveillance is also getting boom nowadays. So when we know how to implement technological surveillance properly, definitely it is going to be one option to control or to minimize the use of physical restraints. And when we discuss about protocols of restraints, so as I have mentioned you, there are alternatives to the use of protective restraints. So when the doctor tells us to restrain the patient as the patient looks irritable, first we should try with some of the alternative techniques. What are those alternative measures? Increased observation. You more and more you observe the patient, more and more you monitor the patient. You try to avoid applying of physical restraints to the patient, because every restraint, every equipment we are using in the restraint has got its own disadvantages. So as a nurses, we should try to increase our observation. We should frequently monitor the patient, ask family members to sit with the patient, alert other staff members to be observant. So do this intervention. Then accurate client assessment for the risk of falls, and placing the patient near to the nurse's station so that we can always monitor the patient. We can always keep an eye on the patient, whatever you are doing. And use a bed alarm system, which senses when the patient gets out of bed and when patient steps on it when getting out of bed. Provide a familiar environment. This also will help to avoid restraint. Floor cushions or floor pads can be provided. Answering the call signal properly. These are all some of the alternative systems which helps us to minimize or to control the use of physical restraints. So this is one example is bed alarm system. So what is bed alarm system? You can see in the image, when the patient's hand or leg, when it is crossing the alarm, when it is crossing one particular part of the bed, it gives us an alarm that patient is moving from the bed. So by listening to that alarm, we'll attend the patient immediately. Here, attending of the patient is very important. In spite of repeated alarms, if you're not going and attending to the patient, it is purposeless. So the patient may fall definitely. So when we are using bed alarm systems, we should always keep an eye on the alarm. We should hear alarm, and when we hear alarm, immediately we have to attend the patient. And this is the example of floor alarming system. When the patient keeps leg or hand on the floor, it gives us an alarm. Then we have to attend the patient immediately. If the patient is moving for some other purpose, you can provide assistance. But when you see that the patient is going to fall, then we have to implement our own nursing measures. And this is instant notifications that when patient moves or when patient comes down, it also gives an alarm. So this is floor cushion. When we provide floor cushions, some kinds of falls can be prevented. So this is when we spread the cushions entire floor of the room of the patient. This can prevent fallings and the injuries related to fallings. And this is providing familiar environment, which is nothing but providing walkers, canes, sticks to the patient so that we can prevent falls of the patient. And these are some of the alternatives which nurses have to use first. When all these alternatives are failed, then based on the doctor's orders, you have to go for restrain the patient. And as I told you in the introduction, restraints are always considered as a policy rather than a general procedure. There is a legal risk of restraints. The patient may be harmed physically and emotionally because of our restraints. Of course, it is for the safety of the patient, but still it poses a high risk on the physical status as well as emotional status of the patient, because most of the patients will feel emotionally depressed, isolated when we restrain the patients. The problem with using restraint is that it opens up a whole plethora of legal issues. At the same time, if we are not applying restraints in time also, we are answerable. So it is a crucial situation for the nurse. We have to apply the restraints. At the same time, we should take all the measures that we should not get any legal allegiance from the due to applying of the restraints. When using restraints, you need to understand how to document properly and accurately, because this documentation shows as evidence for your entire procedure, whatever you have done for the patient. Conduct a contraband search and maintain restrained patients in a controlled and calm and quiet environment. Perform frequent monitorings and clinical assessment of restrained patients. Document whatever you have assessed, whatever you have found, whatever you have monitored, whatever you have observed in the patient. Everything has to be documented. Based on that, our plan of care has to be changed. And this is one case scenario where the nurse has been alleged as failure to properly assess and monitor the impaired and restrained patient. So as per this, one patient was intoxicated and aggressive, brought to emergency department and had to be restrained. Shortly after an assessment check, the patient attempted to burn off his restraints with a cigarette lighter. He suffered severe burns over 25% of his body, resulting in permanent disability. He had undergone some finger amputation. So the defendant nurse has performed patient monitorings, assessments for every 15 minutes. Everything has been documented. But the only thing is the patient had a cigarette lighter. Somehow she missed to assess cigarette lighter with the patient. And because of her busy schedule, one time she missed assessing the patient. The next minute, the patient had tried to burn off the restraint with the cigarette lighter, and unfortunately, the total body of the patient has been burned off, especially the fingers. So this is one scenario. This tells us one point that we have to assess and recheck the patient. Contraband assessment is the same. Of course, the hospital people will assess that there is some security people will assess when the patient is coming to ICU. But before applying restraints, we should assess for any devices with the patient, because maybe cigarette lighter or some nail cutters or some blade or some sharp instruments, the patient is trying to remove the restraints. As a process of that, there is a chance to get injury to the patient. And this is the other case from National Review of Restraints related to deaths. So Loretta was a patient. She was 88 years. And in the 2 days before her death, she had been sitting in her wheelchair restrained with a lap belt. And 3 times a staff person found the use of belt unsafe, as it had not been effective at keeping Loretta properly seated in the chair. On the day Loretta died, staff members reported they found her twice sitting on the floor with the lap belt still attached to the wheelchair. And once with the belt around her chest, the second time the belt was around her neck, and she went to asphyxia. No changes were made at care plan by seeing that situation also. At last, the patient has expired. So what is the purpose of our reassessment? When we go and assess the patients, we should see whether the restraint belts are in place or whether there is any displacement of the belts. Instead of putting it on the abdomen, when we put it on the chest, it causes asphyxia. When we put it on the neck, it also causes the patient to die. So it is very important you just not only assess the vital signs of the patient and skin of the patient, you also assess for proper placement of the belts or devices, whatever we have applied. See, these are some of the examples where the patient have applied for abdominal restraints, but unfortunately due to her violent behavior, at last the belt has tied to her chest and caused asphyxiation. This is the other scenario where the patient had went to the edge of the bed where the neck is compressed between side rails. And here the abdomen of the patient has been hanged to the bedside rail. And this is the other scenario. And if you see the right side diagram, just the restrained belt has been tied on to the neck and the patient has been arrested with the side rails of the bed. These are some examples which tells us one point that we should monitor the patient once in every 15 to 20 minutes. Anything may happen within few seconds. So every 15 to 20 minutes, you observe the patient. If any modifications to be done, that has to be notified in your documentation. So we have to take urgent action in some areas when we are unable to detect a pulse in the extremity where the restraint is applied, when the extremity looks cold, pale, blue tinged, red and purple color, when the patient complains of pain or discharge or numbness or tingling in the restraint part, when the breathing is impaired, especially in case of vests or the abdominal belts, when there is a strangulation of the restraints belts around the neck or the chest, and be alert for vomiting. If the person vomits, a medical emergency exists. If the person there is a chance for vomiting, there is a chance for aspiration. So we should remove restraints to such people and release individuals who are snoring, as this can be a symptom of the sleep apnea that increases the risk of death. When we see all these actions with the patient, we should take an urgent action and we should remove the restraints and do observe the patient as per the hospital protocol. And we should remember that restraints must not be used for convenience or discipline. It is just to save the life of the patient under extreme circumstances. When all our nursing alternatives are failed, then only we have to go for application of the restraints. And there is a law under IPC section 97 covers about restraints and seclusion. This tells us restraints are not to applied just as a form of punishment or just to keep the patient calm. If we do that, we are liable to legal punishment. So that's about my presentation. I request Dr. Viswa Jyothi Madam to add up points, if anything.
Yeah, this is a very extensive topic about restraints, and she regarded it as well. And we should first know what is a restraint and how it should be applied, what are the orders, and when to remove it. Restraints are not given consent. We have to take consent before giving restraints, and that order should be renewed every 1 calendar day, every 24 hours. Without that, we should not continue for a lifetime. Like if they are in ICU, we should not continue until they are in ICU. Because once doctor written the restraint, we should again renew it after 24 hours. And after 24 hours, again the physician will check and again write a new renewal. And restraints is not for we should not just to secure the IV lines and just to prevent the removal of the endotracheal tube. And this is not to restrain entire physical body of the patient. We should make a restraint just use it to prevent the IV lines and all those things, monitors, they should not fall. Mainly for those things we have to restrain, not to punish the patient. So we have to renew it every 24 hours. If it is an emergency, if the physician is not available, if they give oral orders for restraints, they should be signed within 12 hours. Within 12 hours, we have to sign it for the restraint order. Otherwise, we are liable to medico-legal problems. Mainly those things. And again, one thing she mentioned at the last, which is an emergency. Because restraints, most of the times we used to give restraint for wrist. So we have to check for the perfusion of the limb. Otherwise, it's a big medico-legal emergency and also not for the medico-legal. And this is safety of the patient is mainly important. Because if you lose the limb for purpose of the treatment, there is no point in treating the patient. So we have to check for the circulation and also vital signs of the patient and give freedom. If any oral orders are given, like if they are eating, we have to remove the restraints for every 2 hours to make the physical needs of the patient, to put a bedpan or to take water or meals, anything like that. We have to remove the restraint every 2 hours. First is to check every 15 minutes and also to reassess every 2 hours, and also again 24 hours there should be a new renewal order. That is the main thing, and main purpose is to prevent the endotracheal tube removal or Foley's removal and to continue the treatment, and also for the monitors. they may fall onto the patient and to continue the treatment of the patient. It is not just to punish the patient. That is the main things to see for a patient who is on restraints. And we will go for questions.
Yes, ma'am.
Shall we go for questions? In chat box, you can message the answers. What are the restraints? It is a medical or chemical way to restrict the voluntary movement or action, or a physical or chemical way to restrict voluntary movement or behavior. C is a physical or mental way to restrict voluntary movement or behavior. D is a chemical or mental way to restrict voluntary movement or action. You can answer your answer in your chat box. Okay. Yeah, most of them are giving answer correctly, and it is the main physical or chemical way to restrict the voluntary movement or behavior. That is correct. B. Second question is how often should physical restraints be checked? It is every 5 minutes or 10 minutes or 20 minutes or 15 minutes. This is a second question you can answer. Yeah, second question answer is A.
Hello, madam, your voice is not audible, madam.
15 minutes. Third question. Restraints are used to A, to prevent injury to self and others. D is to prevent resident from getting out of bed. Third question. Oh, sorry. Third question. Restraints are used to. The answer here is B. It is not only to prevent the falls. It is to mainly continue the treatment and to prevent injury to self and others. Restraints are used to prevent falls, but it is up to 85% only, but mainly to give treatment. So the answer is B here. Only to protect resident during treatment and to prevent injury to self and others. That is the also advantage of restraint, to prevent falls. So mainly here answer is B for third question. Fourth question is before a restraint is used, an order should be written by. Means the answer is physician. Yeah, most of them are correct. It is physician who should give in the orders. Fifth question is the most serious negative effect of restraint use is. One is loss of self-esteem. B is loss of independence. C is stress and anxiety. D is death. Yeah, most of the answers are wrong. This is mainly loss of self-esteem. Death is the serious event we know.
Jyoti madam, your voice is not audible, madam.
Yeah, sixth question will continue. Just give the answers. Our aim is to continue the treatment. Those are next things to prevent falls or sliding out of bed and to prevent rest death. Main thing is to keep limbs immobilized for IV treatment. Yeah, seventh question. When to the side rails, tie the straps to mobile part of the bed frame, tie the straps with a square knot, or tie the straps with a quick release knot. The answer. You can type your answers. This is mainly tie the straps with a quick release knot. And the answer is D. Eighth one, restraint should be used for the convenience of staff. Yes or no? You can answer it correctly. This is no. The commonest restraint used by you or health professional is whether it is a physical restraint, chemical restraint, or technological restraint. The commonest one. Yeah, it is physical restraint. Next question. Tying alternatives to restraint help avoid the unnecessary use of restraint and should never be used in a healthcare facility. It is a waste of time for staff. Involves the same alternatives for each patient. Yeah, answer is A. It helps avoid unnecessary use of restraints. 11th question. Which of the following is not considered a physical restraint? Sedating medication, geriatric chair, side rails, vest restraint. Yeah, sedating medication is a chemical restraint. So answer is that. What is the most commonly used physical restraint in medical care? Bed rails, wrist belts, abdominal restraint, jacket restraint. Most of them are giving answer correctly.
Yes, madam.
Yeah, correct.
That's it, ma'am.
Bed rails. Thank you, everyone. We'll close the session.
Thank you, Jyoti madam, for giving guidance to present this session. Thanks to ISCCM for giving me this opportunity to present a topic regarding restraints. Thank you everyone for your patience listening.